Today's symposium is entitled, "In the Era of AI and Digital Transformation, Every Challenge Becomes an Opportunity to Rethink, Reinvent, and Reinvigorate Our Approach to Patient Care." I will be having, at my great pleasure, a fireside chat with Dr. Toby Cosgrove, who is the former CEO and current executive advisor at Cleveland Clinic, as well as a strategic advisor to Care Centrix. I'm Ken Mandl. I direct the Computational Health Informatics program at Boston Children's Hospital, and we host this seminar series. You can learn more about us at www.chip.org. Landmark Ideas features thought leaders across healthcare, informatics, IT, big science, innovation, and more. I'm going to introduce Dr. Cosgrove briefly, and then we'll have a fireside chat. And as we get started, you should feel free to begin to put your questions into the Zoom Q&A box below at the bottom of your screen as we go. And then we'll have a few closing remarks. Dr. Toby Cosgrove is the former CEO and current executive advisor of Cleveland Clinic. He's an expert on health issues. He's a frequent commentator in national and international media. He's one of the most storied CEOs in healthcare in a generation. As CEO and president of Cleveland Clinic from 2004 through 2017, he led the $8 billion organization to new heights of achievement and efficiency, seeing it ranked the #2 hospital in America. In his role as executive director, he's working with the Cleveland Clinic leadership on strategies for national and international growth. I thought it was important to mention that in 1967, he's a heart surgeon in the U.S. Air Force, earning a Bronze Star. And with that, I'm going to stop sharing, and we can start to enjoy learning from Dr. Cosgrove in a chat format that, again, I want all of you on the Zoom to participate in. So, Dr. Cosgrove, just a real pleasure to see you again and to see you here. I'm going to start off by asking a broad question. Reflecting on your career, what have been some of the most surprising challenges you've witnessed in healthcare, and what has remained constant in those challenges that you see going forward, despite a lot of evolution in healthcare since you got started?
Oh my gosh, it's hard to, well, first of all, thank you very much for having me here. I'm delighted to have the opportunity to chat with you and share ideas. There's been so much change in healthcare, but I think the thing that probably strikes me the most is the incredible growth that there has been across the healthcare system. Just to give you an example, when I joined the Cleveland Clinic, it was one hospital and 200 doctors. It is now 23 hospitals, 80,000 employees, and 3,000 doctors across 3 continents. And I think this is just typical of what has happened. It's grown, healthcare has grown to 17.3% of the GDP and 17.8% of the total number of employees in the country. It's a huge industry. And I think the thing that has remained the same for the most part is we're still dealing with sick care, as opposed to trying to move on to well care and preventive care, and looking at the opportunities to predict the predictive care.
You know, as you describe your experience in that level of growth, it's really not just the pure growth, but you presided over a period where the business of healthcare really became a much more predominant feature
No
of
question.
what is the job of the CEO. And is that, where do you see that driving efficiencies, and where do you see that perhaps driving us not always in the right direction?
Well, I think there's been, I don't think we've been particularly efficient at what's gone on. One of the things that's happened over the last 50 years is we've seen a 3,000% increase in the number of administrators in healthcare, which has added substantially to the cost of healthcare. So I don't think and the productivity gains have not been what we would like. And in fact, recently, we don't compare very favorably with other nations in terms of either cost or the healthcare that we're providing in this country in terms of longevity. So I don't think that on the whole, we have achieved as much as hopefully we could have, or what is possible.
So if you were pitching for the job that you had today, in your job talk, you could pretend this is your job talk. What would you be promising to do over the next 10 years, given where we are today? If you had that opportunity again.
Well, I think the thing that is going to save healthcare as we know it now is AI, and particularly generative AI with large language models. We have a number of very big problems. And just to enumerate a few, the financial stress that is on healthcare in terms of the cost and the financial viability of our healthcare organizations, the labor shortages, which we are experiencing, and the inflation and the cost of healthcare. I think also we're seeing the disruption of healthcare with many startups beginning to materialize. It's a little bit like nibble, 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 who's nibbling at my house? Finally, I think one of the very big things that we're seeing is the explosion in knowledge with, the total amount of knowledge now doubling every 73 days, that a third of all the data in the world is now thought to be healthcare data, that there are now 1.8 million medical articles written annually. There are 20,000 drugs approved by the FDA. Who in the world can even begin to keep track of all that? So I think these are enormous problems, and that I would pitch that our solution and our salvation in that for those problems is going to be generative AI.
So I want to pursue the generative AI conversation in some detail, but let me jump back first to something you said. So you're talking about startups, nibbling at our ankles, and sort of, how does the healthcare system, accommodate this level of change? I remember when I was in close touch with the founders of MinuteClinic when they first emerged on the scene, very innovative platform. And there was a lot of concern among healthcare leaders that they would begin to make their way up the Clayton Christensen disruptive innovation food chain and go from strep throat and tinea all the way up to certain procedures, and start to really nibble away at our profits. And yet today, there was just a big article in Stat News within the last week or so, showing they have enormous staffing problems. They're actually reducing their footprint, not increasing their footprint. CVS is having trouble even filling prescriptions, their core business, much less performing our core business today. So what was your attitude, when convenient care was emerging during your tenure, because that was during your tenure, and where's that going to go now? It seems to be going in a completely different direction than people were concerned about.
Yeah, and frankly, I thought that this was something that we should try to embrace in terms of our healthcare, and we were some of the first people to have a relationship with CVS over time, thinking that this would be an entrance way for, particularly for primary care, and it would be essentially something that could be a referral source as we went forward. I think the thing that is going to disrupt that is we're going to see particularly generative AI come along that is going to be able to answer a lot of these particular questions. You know, it's perfectly possible that with bots and generative AI, we're going to be able to see a primary care physician double, quintuple, maybe 10 or 20 times the size of their practice. So surprisingly, you may find that you're going to be able to see more patients and have less of a shortage of primary care physicians as we did in the past, and hopefully at the same time reduce the cost of doing that.
So, you know, here in Boston, Mass General Brigham has closed its doors to new patients in primary care. This strikes me as an incredible opportunity for artificial intelligence because there's nothing to displace. It's not even there. And so it will be pulled in, I would imagine, in ways that where it might have previously been more resisted in just out of pure necessity. It may really. Do you see this as an accelerant?
I do, and the interesting thing about new technologies as they come along in the past is there's been an adoption, a paradigm really, or problem in terms of adopting these, and it's been very slow adopting. Look at the adoption rate of electronic medical records. Now there's no hardware involved, and it's purely software, which is getting better all the time just by sheer amount of data that is involved. And so I think you're going to be able to have physicians and particularly primary care physicians look after more patients. And this necessity and this demand is only going to accelerate the adoption of that sort of approach.
And so, speaking of electronic health records, you also presided over the whole meaningful use program, and they have had their. It's not easy implementing an electronic health record system at the scale that you're working at. Do you think that it had a just not considering the future when we start layering generative AI and using these data in perhaps more constructive ways even than we do today, but up until now, do you see that as something that was more of a promoter of your business and your quality of care, or something that was really more of a challenge?
Well, we adopted Epic in 2006.
Yeah.
As one of the really early adopters of it, and I think it was a step forward for us because it made transparency of patients' records across the entire system, and frankly, it wound up as an early adopter. We grew with it over time rather than trying to swallow the whole elephant in one bite. So it was incremental for us as it was more difficult for people who came on later.
So would you see that as the primary advantage during your era, was the transparency and sort of defragmentation of information for your patients across the care sites?
It was certainly an advantage for us. There's no question about that. And in retrospect, I wouldn't for a second have not done it.
Mm-hmm. And so So let's think for a minute about AI. And I'll ask people again, questions are starting to come into our Q&A. Folks can really have an opportunity to interact with Dr. Cosgrove and ask questions. So drop them in the Q&A box down at the bottom. So of generative AI, there's a lot of progress in healthcare. There's increasingly inexpensive omics measurements, including genomics. There are incredible advances in imaging and surgical procedures, ICU care. Where would you put generative AI in the sort of like the top sort of bright lights for progress in the future?
Well, I think it's going to start. It's got enormous opportunities in multiple areas, but I think the first place it's going to start is going to be in the administrative efficiencies of hospitals. Just for example, the Cleveland Clinic now has 3,000 people who work in revenue cycle, 900 people in call centers. These easily be organized in such a way that you can reduce the number of people and hence the cost of care. Similarly, the doctor's inbox. Think about also what you see now with ambiance and nuance that are coming on board that are help the doctor. But I think the first place you're going to see it is in the administrative area because, frankly, doctors are very slow to take on anything new. And are resistant to change. And I think that it will, they will be slow to adopt it. I think it is about 10% of physicians now would suggest that they're using chat, for example. I think you're going to see chat get better as you saw from going from 3.5 to 4.0, enormous improvement. I think that the problems that we see with generative AI right now are frankly cost, bias, and hallucinations. And I think those will continue to improve as we go forward. This is really early days of what we're seeing. And I predict that we're going to see the hallucinations go away and gradually, like most things, the cost come down.
So, and how do you see this? As you were obviously involved in an unimaginable number of procurements in that time, including Epic, which was a large one, and I'm sure other large scale procurements. Where do you think is where do you think it's optimal to sort of be able to engage people in your position and people in smaller systems and with less experience, but in the CEO position? Is it really that what's kind of one-stop shopping with a couple of sort of large players is going to be how this shakes out because of sort of ease of use and access? Or do you think there will really be a long tail of AI, generative AI solutions that end up in different roles and in different systems, in different healthcare institutions, having very different bouquets of these?
Well, I think it's interesting that the question really is who's going to be the beneficiary of generative AI? Is it going to be the incumbents or the new players, of which there, I guess, 13,000 new Silicon Valley startups that are involved in AI? And interestingly, the issue is going to be who has the data. And the data right now reserves with the incumbents, which will give them a substantial advantage. And I think that this surprisingly will, if the incumbents move on this and use their data, this is a tremendous advantage for the incumbents. I looked at, for example, Cleveland Clinic has recorded all the parameters and outcomes for cardiac surgery since 1972. You can imagine what a huge data set that is, and the potential of things that you could glean from that if you had the opportunity to put all that data in and ask the questions that would emerge from that. So my sense would be you have to first engage administrators. And then one of the things that the Cleveland Clinic has done recently is they've given every doctor the opportunity to put chat on their laptop. And this, I think, will encourage doctors to not be so afraid of it, and to eventually have an appetite to engage with it.
So let me take a couple of questions from the Q&A, and folks can continue to put in their questions. Here's one. Health systems seem to be struggling more so in rural settings. There are mergers everywhere. Is healthcare going to sort of stabilize in cost and patient volume in smaller health systems?
I think the problem that we have is that the rural hospitals are in tremendous jeopardy and closures. I think we're something like 250 hospitals, particularly the majority of which were rural hospitals. And I think that, hopefully they'd be able to democratize the delivery of care, and particularly for less acute issues, and the continuing improvement in transportation begins to solve some of those problems. Do I think that you're going to continue to see consolidation of healthcare, of hospitals? I do. I think the Federal Trade Commission has put a halt to that recently, but nonetheless, I think you're going to see that no longer. I think increasingly you'll be able to have a system that will not have to rely on geographic centricity, and that you'll be able to manage hospitals distantly for greater efficiency, and this begins to change what a healthcare delivery system looks like. Instead of being a holding company, it becomes a healthcare delivery system.
So another question, Asim Ahmed asks that the EMR is an improvement, but the information is still very fragmented, and that in order to understand a patient's trajectory and past history, there has to be we still don't have a good synthesized overarching view of that situation.
Well, that's the beauty of generative AI, because it can pull in data from even structured or unstructured data and pull it in from multiple sources. And I think if you look down the line, you can imagine that you can pull data that will bring in not only where you live, but what you're exposed to, and all of the data into one location and synthesize it in very progressive and thoughtful ways that it begins to be predictive for your healthcare. So I think that this changes from just going from electronic medical record, which, as he points out rightly, that is fragmented, to structured and bringing structured and unstructured data from multiple different venues together in one place for the benefit of the patient.
Let me pivot slightly to an issue that's definitely increasing in significance in healthcare, and that is the significant entry of private equity, especially private equity purchasing practices, hospitals, and I think questions potentially about the commitments to mission from those entities, and the necessity for efficiency in order to meet the goals of managing the investment. How is that going to play out?
Okay, well, so private equity is going primarily to its primary care. And if you look at primary care right now, 50% of the, almost 60% of the doctors in the country are employed. And not all of them. And so going back to the discussion that we had earlier about incumbents, if you stop and think about who is going to have the data and the ability to provide that sort of data, is it going to be the private equity players, or is it going to be the large systems that have the data that can provide? So I think it's going to push more and more people to be in the employed model of healthcare, simply so they'll have the opportunity to do that. And it's not clear to me that private equity is going to have the ability to provide that sort of capability.
And so the capability that they won't be able to provide is, you think,
they're not going to have the sort of, they're not going to have Boston Children's Hospital's data set and expertise from the 100 years of collecting data and knowledge that you're going to have.
Yeah. And, because there are sort of, there are intermediaries who acquire large amounts of data. So there are companies that offer back, so Epic, for example, through Cosmos and other programs that are engendering quite a bit of participation. So is that consistent with your prediction that there won't be access by some of these?
Well, I think that remains to be seen. I'm not sure I have the answer to that. That's my crystal ball is unclear. By the way, you never told me, did I get the job?
Well, the committee's going to meet a couple times. So far, it's looking good, though.
Oh, thanks.
So far, it's looking good. So, yeah, and Adele Stewart was asking something very much along the lines of what we were just discussing with the secondary uses of healthcare data, but more in the context of research and public health. And along those lines, and based on your experience, what do you think is the role of large health systems in promoting a research agenda? So we're a hospital that has a very, very significant research agenda. Boston Children's Hospital, we very large amount of NIH funding for in general, and also for our size. But there, even as we look at large scale academic institutions, there are very strong financial pressures around the delivery side. And under COVID conditions, those financial pressures become more acute. We see this in multiple health systems around the country. What do you think is going to be the role of healthcare institutions, large and small, in promoting the research agenda, both the information research but also the basic science?
Well, let's take what we started with, the efficiency of that can be gained from generative AI and AI in general, taking number of people out, improving the efficiency, etc. That should improve the financial situation of hospitals, and I think that starts a loop, which should progressively allow you to have additional funding for research and for teaching. Parenthetically, let me just tell you, you didn't mention that I am a graduate of the Boston Children's Hospital, having been chief resident there in cardiac surgery. So I appreciate what you do. Without you, I wouldn't be here today.
Thank you. So how do you think there's talk, there are there are sort of catchphrases like blurring the boundaries between research and care, or like research as a care option, or like learning health system from the National Academy of Medicine. How does one promote, if it's a good idea, you can comment on whether it's a good idea, this kind of merging of information gathering and processing and research and learning with the delivery of care?
Well, basically, I don't think that's changed at all over time. We can't do research without the clinical input that goes with it for the most part. And, one hand washes the other. What the clinical brings to the questions for research brings the answer for looking after patients. And so I think they're frankly inseparable. And you have to have organizations like Boston Children's and others to do that research, and that's going to need to, much of it's going to need to be located in clinical institutions. Obviously, the potential for drug discovery can go to the pharmaceutical industry and bring new things to us. That there will be tools, but I think that it's impossible to separate a lot of the research. Because the questions arise there, the problems arise there, and hopefully some of the answers do too.
About healthcare quality, there's been, I think there's interesting progress. Joint Commission under John Perlin's leadership is trying to look for more evidence-based ways to accredit hospitals. We have much more data than we had before to start to monitor quality and compare across sites. Do you think the quality of care has increased in the time in these last couple decades? Let's say since the famous National Academy of Medicine to Err is Human report, have we improved the quality of care? And in that report, there was basically a headline catch and claim that the healthcare system kills a plane load of people per day. Have we are we moving in the right direction, and have we substantially moved in the right direction?
So let me give you an example of what's happened in healthcare, and from one that I was personally involved in. We started recording every patient, as I said, in cardiac surgery in 1972. And every year we did a multivariate analysis of what the causes of death were. And they went from number of vessels disease to left ventricular function to women to size to most recently whether you got a blood transfusion or not. And every year, gradually we progressed. Last year, the mortality rate for coronary bypass surgery was 0. That has only come from looking at the data and analyzing it. And you may be aware that we were, I think, the only hospital in the country that every year publishes its outcomes data for all our departments. And we do that for 2 reasons. A, if you don't look at the data, you don't know what it is, and you don't have a way to improve. And secondly, we think that we are a community resource, and we owe a responsibility to report our results to the community. So I can't tell you how strongly I believe in the importance of both collecting the data and analyzing the data. We spend over $1 million a year just on cardiac data analysis and keeping that, but it has no question that it has improved the quality of the care.
Well, no doubt you encountered some very good record keeping we've had in the cardiology department here at Boston Children's with the filer codes and
Yes.
yeah, and so yeah, those databases are invaluable for
Yes.
understanding outcome. They only exist for relatively small slices of healthcare,
Yes.
from very motivated efforts by monomaniacal champions of these efforts. So this, but reporting, collecting that data, and it will obviously become easier potentially with generative AI and with
Yes.
Analytical AI to be able to just automatically, even just collecting, even just understanding the doctor-patient conversation in the office,
Mhm.
using ambient sound and voice to text is something that will help us collect more data and outcomes. But a question for you is, you pointed out that Cleveland Clinic, and this is extremely admirable, reports its outcomes. Should this be required of all hospitals? If you were running the Joint Commission or advising John Perlin, would you say that, well, that's an accreditation requirement?
Yeah, I think it's going to increasingly be that, and frankly, you're starting to see the same sort of things, and it happened first in patient satisfaction, with Press Ganey collecting the data and recording it. And one of the things that we did is we made that data available online by doctor's name, and gave it to doctors in rank order by doctors. And when we went to medical school, they used to post our grades on the bulletin board, and no one wanted to be last on the list.
Yeah.
Although I was plenty of times, but
Fear.
I think it's important that we're transparent about the data. I mean, that's if we're going to move from the art of medicine to the science of medicine, we have to have data. We have to be transparent about it internally and externally.
Well, Jeff Bezos realized that it's to the platform's advantage to squeeze all the products on those shelves to be reviewed, and to make those customer reviews available to everyone for every product. Actually, it was really counterintuitive to any business that had existed before that I'm aware of, that you would want to show that one of the products you're selling is terrible, because then it forces the manufacturer to improve it or stop selling it. It prevents you from having to make all your process all those returns and lose that revenue, et cetera. So is the hospital a platform for practicing clinicians who are both self-interested to demonstrate their value as a product on the shelf? Is there an analogy there?
Yeah, I think there is. I think that we all have to be accountable for what we're doing, and this is a way to measure the data, is a way to do it. We used to look at the mortality rate by surgeon in our institution, the number of infections, the number of blood transfusions, etc., and it got better with time. And I think if you have a problem, you have to recognize it in order to begin to address it.
We had a famous incident in the Boston area where data were made available through a shared system, and one player, knowing that MRSA rates were lower at their site than at the other hospitals, publicized it. And it was seen as a sneak attack because the other sites couldn't respond in the public, because their methicillin resistant Staph aureus, Staph aureus, the hospital acquired serious infections, for folks who might not know what MRSA is, were higher, and that had a chilling effect. Still comes up today. This probably 2 decades ago that this happened. Still comes up today in conversations about data sharing. How do you see the use of data in competitive arenas, and also in negotiations with payers, right? Those are the areas where people, where leaders in your position often want to actually shut down that kind of information.
You can't shut it down. I mean, I think you would be the first to say that you don't take great pride in Boston Children's Hospital ranking in the U.S. News and World Report.
Right.
And the data that goes into making that happen.
Right.
And I'm sure you work at it like every other institution does to put your best foot forward. You know, I think it only, data only lifts you if you have the data and you make it transparent.
So here's a question that I'm not sure if it's correct, but you've been quoted as referencing what the questioner calls a guts quotient, which I think has to do with how brave you are. And when it comes to the integration of Gen AI in healthcare, what's the gutsiest thing you would do in the name of improving care for patients?
Well, obviously, that's somebody who would listen to a speech that I gave at Williams College one time.
Oh, good. So you're appropriately quoted.
And I think probably better than a guts quotient is perseverance. Might be a kinder word for that. And I think you have to persevere through what is not necessarily making everybody happy. I persevered through making each one of the institutions at the Cleveland Clinic report its data. I was not particularly popular with that, but I thought that we persevered through putting patient satisfaction, making that public. And that was not a particularly popular thing. We persevered through calling everybody at the Cleveland Clinic a caregiver, and doctors said, well, what is this? Patients first, doctors last. So I think you need to have a moral imperative to drive what is the correct thing ultimately for the patient, and that sometimes requires persistence in spite of what other people might suggest.
So those are brave things to take on. I know getting people to share data, to publicly address deficiencies in their own care, that is not an easy thing to get physicians, researchers, professionals to do. So maybe say a few more words about that perseverance in the spirit of sharing some lessons in leadership with folks on the phone.
Lessons on leadership. Well, let me start out by saying I don't think we've done a particularly good job in healthcare. I'll use myself as an example in developing leaders. We don't select people because they to go into healthcare, and we don't train them to be leaders, and we don't give them the experience to do that. And I think if you should think about leadership, and most people would suggest that leaders are made, not born. If you look at how you're going to begin to train leaders, I think there's a couple of models that you would probably follow. I think, you know, the organization that I know that has been at this the longest and has thought the hardest about it has been the military, and going back hundreds of years. And they have a fairly simple model for doing this. They give you in charge of a small group, and if you do well, you get a bigger group. And if you do well, you get a bigger group. Some people do well and some don't. But you learn from that experience. But in between assignments, they give you the academics. They may send you to artillery school. They may send you to the Harvard Business School. They give you 90% experiential learning and 10% academic learning along the way. And when I recognized how poorly I was prepared to be the CEO of the Cleveland Clinic, I vowed that I would try to do better for the next one, and I think I have. We had 250 doctors in some sort of leadership position, and some did well, some didn't. And gradually we sent them to get additional training. We then brought that training in-house for a leadership academy within the Cleveland Clinic that moved on from just doctors into leaders across all portions of the organization. But I think we don't select, and frequently we select people because of the size of their CV. And being a technician or a researcher doesn't qualify you for being a leader of people, which is an entirely different thing. So I think if you're going to lead an organization, you have to have the objective that you want to do. You have to implement it, and either have to pick people who can implement it for you, or you have to have the emotional intelligence to do that. And I think that the higher up you go in leadership, the more important emotional intelligence is. So I've thought a lot about this. And by the way, I think this is incredibly important in the adoption of generative AI. There are probably 150 people who are the major leaders in healthcare in the United States, who are CEOs of pharma or CEOs of hospitals. And the directive to do this is going to be a top-down decision from the top. And those individuals have an important responsibility to take advantage of all the things that potentially could address the burning issues of healthcare in terms of cost, labor, data, and competition.
So what does that, what do you think will define a successful leader in that top-down decision to get AI into the organization? What's gonna separate the wheat from the chaff here?
It's going to be first movers. I think you have to understand that a lot of this is going to be outsourced. I think that is going to move healthcare systems increasingly to diverse locations, and not necessarily all in a central location in a main hospital. And it's going to move it from inpatient to outpatient to home care with remote monitoring. And I think that the push has to be coming from the top in terms of allocating finances, directing that, and insisting that the moves happen. Most important thing about that, I think, is getting particularly the physicians on board, and that is going to require a lot of communication. And that is going to be, I think, the job of the CEO and the CIO going forward.
How would you compare this task that's ahead of us to implementing an electronic medical record system, which all institutions are recently experienced with?
I think in a way it's going to be easier. And the reason I say it's easier is there's not going to be the huge outlay of money. It's going to be, there's no hardware to be purchased. It's all going to be software. It's going to improve continuously. And I think the advantages of it is going to be so obvious once you get into it that, and it's easy to use. I mean, anybody who has gone on chat realizes, how easy it is to ask a question. And the potential that it has, I think it's going to be impossible not to recognize that. So to get people on board and to direct the resources to do it, and to realize that, you're probably not going to be able to do it all in-house. I think you probably will remember when everybody wanted to do their own electronic medical record in-house, and eventually scrapped it and went to Cerner or Epic. Just because they realized that that was not their expertise. Our expertise is essentially looking after patients, educating and researching. It is not necessarily being having a great IT deck and innovating in that respect. So I think there's going to be an opportunity to partner, just like Microsoft and Epic have partnered, use that data. Recently, I sat down with Judy Faulkner, and she said, "Toby, you can't believe the data I got. I looked at lead poisoning, and we could tell where the lead poisoning was the maximum in the country. Turns out it's in the zip code I live in. Who would have thought that Epic could help us understand the epidemic of lead poisoning?"
There's a great, a very nice publication it was actually a collaboration between Boston Children's and Quest Diagnostics, came out in the same space last year. They also have that geocoded lead level location, right? So these very large scale data sets are clearly going to be very, very important. And what advice would you give to people interested in becoming healthcare leaders? There are folks on this Zoom who are in their training and looking forward to what they might, how they might direct themselves, or what kind of experience they might get to not just have that long CV that perhaps misdirects someone to think they're interesting, but to actually be one of these leaders who can deal with the massive changes that are coming to healthcare over the next decade.
Yeah, that's a great question. And, one of the things that I think is incredibly useful is finding people who are curious. And they're curious in all sorts of different areas. And I early on understood that there was somebody someplace in the world is doing something better than I am. And be curious enough to go figure out where that is. And nobody has a lock on knowledge, and it comes from all kinds of funny places. And to be curious enough to go figure out where it is and where it comes from and how you can implement it, I think is a unusual but a very valuable opportunity.
And what about the caretaking side? It's people thinking about medical school today are looking at a very different job than people 10, 20, 30 years ago. 30 years ago probably much more resembled 40, 50, and 60 years ago than these other time points resemble more recently and where we're going in the future. What would you advise someone interested in medical school? Is it a good profession for them to go into today? And what should they expect?
I think it's a great profession. And where else do you get paid for looking after people? I mean, the pay in psychic capital exceeds the pay in monetary forms. And the respect, the satisfaction that you get, the fact that we're physicians are always going to be solvent, and they have I wish that I was 25 years old again so I could participate in the incredible things that are going to happen. Let me just give you one example that I'm working at a company right now. It is manufacturing lungs. They're 3D printing lungs and down to 5 microns for the capillaries and alveoli, and they're doing the same thing for livers and kidneys. Now, can you imagine and they're going into animals this year. Can you imagine what that means for the potential? It's incredibly exciting. And the potential to change lives just is stunning.
So that's a very inspiring example. And perhaps sometime we can hear more about that work. But I'm going to take advantage of that very high note for the future, where there's a lot of rosiness in the outlook despite the challenges. And you and I agree that there's no greater reward than what you get back from a patient whom you deliver care to. But I think it may be a somewhat different phenotype that's going to succeed in the future, perhaps, as physicians, given that, you know, there's very different challenges to negotiate, and it'll be very interesting to check back in. So, Dr. Cosgrove, I can't thank you enough for joining us today. I've been wanting to get you into this series for a period of time, and we got it scheduled.
Well, thank you for the opportunity, and continue the great work at Boston Children's Hospital and leading the thought processes on innovative ways to manage the data in healthcare.
Thank you. I'll just wrap up with a little look at what's coming next. We will be seeing Chrissy Farr, who's now a health tech investor at Omer's Ventures and a former very well-known technology and health reporter for CNBC, just about a month from now. You can register for this at chip.org/events, or just go to chip.org and you'll find the events on the webpage. We're very eager to hear from you. We're easy to find. And we have, in addition to our seminars, we've got postdoc positions and a lot of collaborative opportunities as well. So thank you, everybody, for joining, and we will sign off.